I am Dr. Rajendra Nagarkatti, Chairperson of the FOXY Midlife Management Committee, and on behalf of the Federation of Obstetrics Gynecological Societies of India, that is the FOXY, our Honorable President, Dr. Alpesh Gandhi, sir, on behalf of the Indian Menopause Society, our Honorable President, Dr. Alpesh Gandhi, on behalf of the FOXY and our Honorable President, Dr. Alpesh Gandhi, on behalf of the Indian Menopause Society, the IMS, and our Honorable President, Dr. Jignesh Shah, on behalf of the FOXY Midlife Management Committee, myself as the chairperson, and our Honorable Vice President in charge of this committee, Dr. Anita Singh, Madam. I welcome you all to this webinar, which we have on menopausal syndrome and its management. In today's COVID times, we are all in our own capabilities and specialities working towards taking care of our patients and of course of ourselves. And we have had a lot of seminars and webinars on the novel coronavirus, its pathophysiology, its prevention, management, etc. So today we are here to discuss on a different topic, and that is women's health. We all know that women's health is very important to the society and to the family, because it is the woman who takes care of all the different family members. And so we are here today to discuss her health at a very crucial juncture of her life, and that is the menopause. The menopause at one time was considered as by the women as the beginning of the end. But today, with an increased longevity, we consider it as the beginning of a new phase of life, and that is the midlife. And we are here to discuss the different problems and issues that they may face at this time. So to solve your queries, we have a galaxy of experts with us today, and I would like to introduce them to you. To begin with, we have, as you can see on the screen, Dr. Jignesh Shah, who is currently the president of the Indian Menopause Society. He is doing private practice since the last 34 years in Ahmedabad. As I said, he's the president of the Indian Menopause Society. He was the organizing secretary of the 2020 West Zone Yuva FOXY at Ahmedabad, vice president of IMS previously, and past president also of the Ahmedabad Obstetrics and Gynecological Society. He's got a number of papers and publishings to his credit, and a special area of interest is, of course, high-risk pregnancies, menopause, and fetal medicine. The next panelist that we have with us today is Dr. Parag Biniwale, Dr. Ratnabali Chakravarti. Dr. Ratnabali Chakravarti, madam, she practices obstetrics and gynecology at Kolkata. She's currently a consultant obstetrics and gynecology of the Columbia Asia Hospital in Kolkata. She is a past president of the Indian Menopause Society 2018-2019, vice chairman of the All India Women's Cell of the Indian Medical Association, Women's Cell of the Indian Medical Association, Bengal State Chapter, state coordinator of the Mission Pink Health Project, and a member of FOXY, a founder secretary of URGO. The next panelist that I would like to call upon is Dr. Ashwini Bhalarav Gandhi. She is a consultant obstetrician and gynecologist at the PD Hinduja Hospital and the Hinduja Healthcare Surgical Hospital, Mumbai. She's currently the president of the Mumbai Menopause Society 2019-21. She's been a vice president of the FOXY, the Federation of Obstetrics and Gynecology, 13. She's the president of the MOGS, the Mumbai Obstetrics and Gynecological Society, between 2012 to 13. She was a chairperson of the Adolescent Health Committee 2004 to 5. She's been an ex-associate professor at the TN Medical College and Nayar Hospital, and she's also the secretary of the Journal of Obstetrics and Gynecology of India. She is a consultant gynecologist at the Valva Clinic at Hinduja. The panelist that we have with us today is Dr. Parag Biniwale, a senior consultant obstetrician and gynecologist at Pune, and a unit head and PG teacher at the Kamala Nehru Hospital. He is currently the secretary of the Indian College of Obstetrics and Gynecology, the ICOG, up to 2020. He is also the president of the Menopause Society Pune. He is a national joint secretary of the IMS, national website editor of Foxy, a peer reviewer for the Journal of Obstetrics and Gynecology of India, chairman Young Talent Promotion Committee of Foxy 2008 to 10, a master trainer for adolescent-friendly health services, conducted various workshops, delivered oration guest lectures in over 120 Foxy societies, and recipient of the Dr. C.S. Dawn Prize at the 51st All India Congress of Obstetrics and Gynecology. And finally, last but not the least, we have Dr. Pratik Tambe, who is an ART consultant and a gynec endoscopic surgeon. He's received the International Diploma in Advanced Laparoscopic Surgery from Clermont, France, trained in ART Brussels, Belgium. He is currently the chairperson of the EMOGS Endocrinology Committee 2020 to 22. He is chairperson of the Foxy Endocrinology Committee 2017 to 19. He's a managing council member and patron of the Mumbai Obstetric Gynec Society, managing council member of IAG, MSR, AMC, a mentor for the MOGS Youth Council. He's received various awards. He's editor of various books, 3 Foxy Focuses, handbooks, 11 key practice points, contributed and published over 50 chapters. He's editor of the Foxy Insight Reaching Out newsletter, and various other publications. So we have all these different experts, and we are all going to discuss and deliberate on the problems and issues that are faced by women at this particular stage. So now, moving on to the first case, I would like to hand over to Dr. Ashwini Balarav Gandhi, Madam, to take on proceedings from now.
Can I have the slides, please? Subbu?
Sorry, एक second.
Yeah.
Madam, yeah, we are just sharing. Just a second.
Dr. Nagarkatti, till we are ready with the slides, would you like to start with Dr. Pratik Tambe's case or my case?
Dr. Pratik is the first to start. Dr. Pratik, please start.
So, good evening, everyone. It's lovely to be here. And can we have the slide, the question on the screen, please? Subbu session. Can you do a screen share and show us the slide of the case? Yeah, fantastic. So this is a practical scenario which many of us face in clinical practice quite regularly these days. And I thought it was particularly relevant because a large number of women now are choosing either to have children, the first child, quite late in life because of changing socio-demographic profile, or it may be that for some reason they're opting to have a child a little later in life, and they come with a certain peculiar set of issues which are unique, and I thought it would be relevant to discuss them here, especially since we are talking about fertility in the perimenopausal age group. So Mrs. ABC, a 42-year-old housewife, had initially planned to have only one child. She had a son who was conceived spontaneously, had an uneventful antenatal period delivery. That child had average performance in school and college, but unfortunately has passed away in a road traffic accident recently. The lady has now recovered from the initial phase of bereavement and depression. The couple wishes to explore the possibility of having a second child. Next slide, please. Subbu? Yeah. So the questions that we want to ask here are, is natural conception a possibility in this couple? Do we need to investigate them? What investigation should we advise? How do we counsel this couple at this very difficult juncture? Because it's a very difficult and traumatic period of their life. At the same time, time is a concern because her age is already 42. She's in the perimenopausal age group. They will have their own unique concerns regarding fertility, abnormalities in the second offspring, and finally, we'll talk a little bit about what the treatment pathways and the choices are when we offer treatment to such a couple. So, starting off with the very basic and first question. Yes, natural conception is possible even beyond the age of 40. But if you recall your medical textbooks, which we read during our MBBS days, you'll find that pregnancy at this age, beyond 40, up to the age of 45, is the exception rather than the rule. The incidence of a spontaneous pregnancy in a couple who's trying at this age is usually in single figures. The time taken to pregnancy, of course, is a significant factor, which is of prime concern in this particular couple. So obviously, yes, you would counsel them that certain investigations would be required before they try for a child at this delayed age. Some basic investigations such as the husband semen analysis, a baseline hormonal profile in the female partner, ovarian reserve testing, ultrasound, and infection screen are all what are recommended as a bare minimum set of investigations. There are others as well, but we will try to stick to the basics here since this is a very preliminary discussion on fertility. If we talk about fertility in the perimenopause, I'm pretty sure with the galaxy of experts that we've assembled, we could have a full day discussion and we would still barely be scratching the surface. It's important to note that counseling forms the cornerstone of all treatment in fertility and specifically at extremes of reproductive age. It's important also to realize that after this woman has conceived, she's going to need a multidisciplinary team who is looking after her throughout pregnancy and the puerperiod. This includes somebody who's experienced in treating high risk pregnancies, a physician who is there available 24/7 in the unfortunate event of a medical emergency. If it is relevant and you find that she's suffering from some form of cardiovascular or you know diabetes sort of situation, then it's important to bring these people early on into the multidisciplinary team right at the point of conception, maybe even before the point of conception. As is important and has already been spoken, since counseling is the cornerstone of all treatment, we need to have a counselor who's a full-time or a part-time counselor attached to your clinic and who can be available at least one phone call away. The specifics of diet and nutrition we will not go into because I think it's more important to address the important issues of when this couple conceive with their own gametes, what is the likelihood of this child being an abnormal child? And this is a key concern for most couples at this age. So it's important for all of us as practitioners to know that the incidence of trisomy 21 and trisomy 18 increases significantly. In fact, trisomy 21 at the age of 20 years, the incidence is hardly 1 in 1500. But at the age of 40, it's less than 1 in 100, which is a very significant increase. And therefore, we counsel such couples that as and when she gets pregnant, we need to subject her to the routine tests, which we advocate now for all women in general. But specifically in this particular couple, we need to ensure that she undergoes the NT scan, dual marker, triple and quadruple marker, and invasive testing if required. Those pathways are already known to us. But what is important is not only that you speak about them, but you address this issue even at the very first counseling session, because this is a key issue which will decide whether they want to try for a pregnancy with their own gametes or they would resort to an oocyte donation cycle. This is a key concern for most couples. If you look at the evidence which is available, there are plenty of guidelines from international bodies, including ASRM, ESHRE, the American College, and of course the NICE Green Top guidelines as well, regarding fertility and fertility specifically in the perimenopausal age group. You will know that the International Menopause Society also has added its own 2 cents to the entire gamut of evidence that's available. In 2012, they came up with the stages of reproductive aging in women. And if those of you who are interested, I'll be happy to share the original paper with you, where they came up with a guideline which is called as straw plus 10 criteria. And these are to be used for women who are trying to conceive in the perimenopausal age group. Of course, this has later on been superseded by guidelines from ESHRE and ASRM, and specifically because ovarian reserve testing has come into our area of expertise in a big way in the past 4 to 5 years. So as far as ovarian reserve tests are concerned, what is recommended is that an antral follicle count and an AMH test should be done mandatorily for such couples. If you find that the AMH is less than 1 and the antral follicle count is less than 4, then this patient is likely to be a poor responder, which is pretty much normal and expected at this age. As far as AMH and antral follicle count are concerned, it's well known that both are very good factors to assess ovarian reserve in these patients, and it's best to combine both of them rather than use one over the other. Since we are running out of time for this particular question, I think I'll move fast forward and try and close this case discussion in just 2 minutes. There are various criteria which have been laid down, which are known as the Bologna criteria for poor responders. And the criteria say that 2 out of 3 criteria must be present to define somebody as a poor responder. Advanced maternal age, obviously, more than 40 years is one very important criterion. The second is a previous poor ovarian response, which is not applicable here, and an ovarian reserve biochemical test of AMH less than 1 or an antral follicle count, which is less than 4. We also have a checklist which was devised by Foxy when I was chairperson of the endocrinology committee. It was released incidentally, Dr. Jignesh, at Ahmedabad only in the ICOG 2017. This was through the endocrinology committee, and one of the key experts who devised this was Dr. Amit Patkia, past president of the Mumbai Society, and Dr. Rishma Dillanpai had just taken over as the president of Foxy at that time. There's also an ESHRE guideline which tells us what aspects of treatment are important and which need to be addressed. I'll cut to the chase by saying that no matter what treatment we do, whether it is IVF, whether it's ICSI, the chances of success in IVF at the age of 40 plus, close to the perimenopause, are usually around 10, 12, 13%. Contrast this if this patient were to resort to oocyte donation. If the patient were to accept oocyte donation, which is mentally not easy for the patient, and it's going to be taken with a lot of, soul searching and difficult to accept, then the chances of success are excellent. You can get up to 50% clinical pregnancy rates with oocyte donation. Again, it's important for us to realize that just getting the patient to conceive is not the battle won. Subsequently, at the end of the day, she needs multidisciplinary care. She needs to have a good physician. She should be registered in a tertiary care institution where all facilities are available. There's regular monitoring. These women have a higher incidence of miscarriage, developing medical complications in pregnancy like hypertension and gestational diabetes, operative vaginal deliveries, instrumental deliveries, cesarean section, postpartum hemorrhage. All of these are increased by 2, 3, 5, 7-fold once the age has crossed 40. And this is something which, as fertility care physicians, we need to address, and we need to counsel and make sure that these couples are aware of the issue. The last point I want to make is that as far as increasing fertility is concerned in this age group, there are certain agents which are androgens like DHEA which are available, but the most recent Cochrane analysis shows that benefit from these is marginal. Your mileage may vary, and at most you can give it for 3 to 6 months before you run your treatment cycle. At the end of the day, oocyte donation is always a better option, but it has to be mentally acceptable to the couple. Can we have that last slide where we have the key practice points? I'll just re-emphasize them. We've talked about natural conception, baseline investigations, counseling, multidisciplinary team. Next slide, please. Appropriate investigations. We've talked about the role of dual, triple, and quadruple marker and invasive testing. We've talked about AMH, AFC, the Bologna criteria, a Foxy checklist. We've talked about how oocyte donation is the best and gives the greatest results. DHEA is possible, but then usually the results are not anything to write home about. And finally, one last word about oocyte cryopreservation. Obviously, nobody knows if their child is going to die in a road traffic accident 20 years later. But this is something which we as clinicians should promote amongst lay persons and society, that because of increasing age of marriage and because of other issues like whatever pandemics which are occurring today, or because of changing socio-demographic profile, more young women should be counseled and should be promoted to undergo oocyte cryopreservation, because that's the best insurance for your fertility in the long term. Thank you so much for having me. Dr. Nagarkatti, any questions you would like to ask?
No, I think it's you've summarized it very well. Would just like to highlight that the way forward would be most likely would be to go for an oocyte donation, because that definitely gives better results. And as you rightly said, because of the increasing age where women are getting married and going for conceptions, oocyte preservation also is definitely the way forward. And also in patients probably who are going for chemotherapy, there is also a role of ovarian transplant, which also probably we just need to keep in our minds. So I think it's very well summarized. I think questions we would take from the audience a little later. We would like to move on to the next set of case discussion. And for that, I would like to just bring a lighter note to this particular discussion. We all know what happens to men when they are asked to pause. They get all jittery and shaken up. So I would just like to sort of lighten them up by telling them that even the women do have the same problems. And so let's see on a lighter note what women face at this time.
This is Maine. Okay, I'll be right back. Mom. What's going on? My vagina is dead! What the hell are you talking about?
That motorcycle guy, I took him back to my place, stripped off his clothes, ran my tongue up and down his gorgeous body and felt nothing. It was like I was licking a rock.
I'm confused. Did you sleep with him or not?
Not. But I mean, I tried, but it was like I couldn't get it up.
I'm sorry, I didn't know it was Take Your Mother to Work Day.
Yeah, it comes right after Sleep with Your Married Boss Week.
Carry on.
Well, well. Who's this beautiful wounded bird?
Don't waste your time. I'm numb from the neck down.
So the head's still in play?
Yes, so we all know that estrogen depletion at menopause leads to urogenital atrophy and the problems related to that. And to discuss that, we have with us Dr. Ashwini Bhalerao Gandhi. So I request Dr. Ashwini Madam to take up her case. Thank you.
Coming to the case of urogenital vulvovaginal problems, we all know that after reaching menopause, there are many changes which are taking place, especially in the urogenital tract. Let us just discuss one case which we see very often in our gynec OPD. A 55-year-old woman who is already menopausal since 5 years. She comes to our OPD with complaint of vaginal burning, itching, dryness. She also complains of recurrent urinary tract infection since last 1 year. And on inquiry, she admits that yes, she is also suffering from dyspareunia. On examination, when we examine her locally, per speculum examination, vaginal walls look pale, vagina is dry, atrophic, and it has lost its rugosity. So we think about doing some investigations, some are routine, some are specific because of her complaints. Definitely one should go ahead and do pap smear with her age. We also should ask for a sonography of the pelvis with KUB before voiding and after voiding, so that we know whether there is any chance of any retention of urine, and that is the reason why she is getting recurrent urinary tract infection or maybe a cystocele. So on examination plus sonography will tell us about the same. Urine routine microscopic will tell us whether she has any urinary tract infection. Some blood tests we can do like CPC, fasting blood sugar, post-run blood sugar to rule out diabetes, so that we know that exactly what is the problem with this woman. Now, coming to the next slide, can I have the next slide, please? Let me just discuss now about genitourinary syndrome of menopause. Earlier, all of us used to just say the woman is having vulvovaginal atrophy or she's suffering from atrophic vaginitis. But nowadays, we are supposed to use this term, genitourinary syndrome of menopause. At a terminology consensus conference of the International Society for the Study of Women's Sexual Health and North American Menopause Society, this term was coined in 2014. Can we go to the next slide? And it describes genital, sexual, as well as urinary changes in the lower genital tract associated with menopause. We all know that lower female genital tract and urinary tract, the origin, embryonic origin is the same. This tract has both alpha and beta estrogen receptors which are present in the urogenital region, and thus estrogen deficiency leads to thinning of the epithelium, means uroepithelium as well as the vaginal epithelium. It increases the vaginal pH. There is a change in the vaginal flora, and there is increased vulnerability to irritation and trauma. So all this will lead. So what are the management options? Every time, whenever we talk about menopause, definitely we have to talk about the lifestyle changes. We also should tell the woman to avoid tobacco consumption in any form. In fact, regular sexual activity will keep the vagina healthy, and many a times because of dyspareunia and even the feeling that the woman feels that I am now getting old and why should I indulge into sexual activity, maybe the activity will become less, and in turn it will lead to more problems. So we have to assure her that if you keep regular sexual activity, that will help improve the vaginal health. We also should tell her to maintain vulvovaginal hygiene, to avoid any alkaline soaps or any use of harsh chemicals and fragrances. She can use vaginal lubricants, especially at the time of keeping relations, and any other time whenever she feels dry, she can use moisturizers. Next slide, please. Coming to the management, we can say the gold standard therapy is low dose vaginal estrogen cream. There is a safety data available only up to 1 year of use, but there are so many clinicians who give this vaginal estrogen creams for a very long time, and they do believe that this is the treatment, especially for the urogenital problems. And in fact, many times the urologist will refer women to us who are suffering from lot of urinary tract recurrent infections, etc. We have different types of creams which are available. We have estriol 1 milligram per 1 gram cream available. We have conjugated estrogen 0.625 milligram per gram of cream available. And one has to tell the woman to use 1 to 2 gram cream daily for 3 weeks. Then we can tell her to taper it, maybe either alternate day or then the twice a week. That she can use for 3 months. And ultimately then we may tell her to stop the cream or use it if required. Here I would like to specially mention, because we run a vulva clinic in Hinduja Hospital, we do get lot of women who have dermatosis, which is associated with menopause. So whenever a woman comes to our OPD, we have to examine even the vulva carefully to rule out any changes of atrophic vulvovaginitis, vulvar lichen sclerosis. She may also have vulvodynia. She sometimes can complain of hirsutism. Many times she can have vulvovaginal candidiasis, especially if she is diabetic. And also very rarely she can have vulvar lichen planus. So if at all we are suspecting any of these problems, we need to refer her to a suitable dermatologist. So the multidisciplinary approach is very important. Now coming to the key practice points. Indian Menopause Society clinical practice guidelines on menopause tell us that the prevalence of GSM is 15%. The suggestive questions need to be posed during history taking because on their own women may not come out with these genitourinary complaints. We may have to specially ask for these complaints. Physical signs of reduced vaginal rugae, pale appearance, etc. should be noted. We can tell her to use vaginal lubricants for treatment of dyspareunia. She can use moisturizers for dryness. Estrogen therapy overall can be given either orally, patch, transdermal, because if she is also having some other problem like vasomotor symptoms or any other psychological problems, only vaginal cream may not be enough. If she is also complaining of mild prolapse of any dribbling of urine or incontinence, we have to tell her about pelvic floor exercises, bladder drill, etc. And some women, even they are on oral estrogen therapy, may require additional vaginal local therapy. Only oral therapy may not be sufficient. Progesterone supplementation and endometrial surveillance may not be necessary in low risk asymptomatic women on vaginal estrogen cream. So all this we must keep in mind when we are dealing with a woman who comes with genitourinary problems and when we are prescribing her any estrogen therapy and especially vaginal estrogen cream. Dr. Nagarpati, I think we can take the questions later on. Maybe we can go to the next case.
Yeah, thank you, Dr. Ashwini, for wonderfully elaborating all the different aspects of urogenital problems. On a lighter note, once again, I would just like to stress to all the ladies out there that you need to continue to remain sexually active in this phase of your life. And of course, if you have problems, you can use some moisturizers like Dr. Ashwini mentioned. So that would be the way forward. And I would also like to stress upon the fact that vaginal estriol or vaginal estrogen creams are one of the safest modes of treatment in terms of MHT or menopausal therapy. The risk levels are very low. And secondly, like she already pointed out, one does not need to give progesterone protection to the endometrium while on topical vaginal creams. So, so that was to sum up this particular case. So now moving ahead, we have the next case. I would like to now invite Dr. Jignesh Shah for his case and presentation.
Good evening, friends. Namaskar to everyone. First, let me start with a big thank to FOXY President Dr. Alpesh Gandhi and Midlife Committee Chairperson Dr. Rajendra Nagarkatti for joining this webinar with Indian Menopause Society. My case, I have decided to divide my case into three parts. So first part is a lady aged 46 years, asymptomatic.
Just to point out that we already have more than 1,500 viewers for this particular.
Oh, that's very nice, very nice. Congratulations.
Thank you, thank you.
She is getting regular periods and she heard she will have lots of problems at menopause. She wants to know what medication to take to avoid problems at menopause. Husband has been vasectomized. Her physical examination and investigations are normal. How will you counsel her? So she is group 1 patient without any symptoms of menopause. Now, next slide. let us start with the question why we are discussing menopause. Because at present, woman is living average lifespan is more than 70 years. Next slide. Many of you will not believe that before the independence, the average lifespan of Indian woman was only 35 years. It was because of high rate of maternal mortality rate, and at present average lifespan is 70. And at present, more than 20 crores of Indian women are living in perimenopausal or menopausal age group. Previously, these women were not seeking treatment and taking menopause and its related problems as a natural phenomenon. But now, in 21st century, the woman wants quality of life. So they are expecting the treatment for the same, and they will be coming to us for the treatment of menopause. So it is very necessary to understand the problems of menopause, the symptoms associated with it, and how to treat the menopausal woman. Next slide. Then there are specific issues related with the Indian woman. First is average age of menopause for Indian woman is 46 years compared to its Western counterpart where average age of menopause is 51 years. So Indian women are getting menopause 5 years earlier. Then there is dominance of non-vasomotor symptoms, mainly psychological, physical and sexual symptoms. And genitourinary syndrome of menopause is highly prevalent in Indian lady. Then again, incidence of metabolic syndrome, diseases like diabetes, cardiovascular diseases, thyroid dysfunction and osteoporosis occurs in Indian women earlier than Western counterpart. There is peak incidence of breast cancer and cervical cancer at an earlier age, and we are living in the country where on one end there is dietary excess and on other end there is extremely dietary deficiency. So these are the specific issues in India. Next slide. So average age at menopause in India is 46 years, and it is important to know one for fertility issues and second for this incidence of metabolic syndrome, osteoporosis and all these things. Next slide. Now she is 46 and still having periods. So what stage of reproductive aging is seen? Next. So this is menopause transition, where it stays there for 1 to 2 years. Now in this stage, if lady wants to know whether I am approaching menopause or whether I am in menopause or not, so whether FSH is needed to diagnose menopause or no, there is a big no, because menopause is a retrospective clinical diagnosis where you are not supposed to conduct any test for diagnosis of menopause, except, as Dr. Pratik has already said, FSH and AMH and AFC is needed to diagnose menopause condition in patients seeking treatment for infertility. Next. Next slide, please. So she wants to know what medication to take to avoid problems at menopause. Next slide, Susan. Yes. Now, as she is not having any symptoms of menopause, we should not prescribe any hormone therapy or other therapy, but this is the window of opportunity, because at the age of 46 when she is coming, that you should advise her about the lifestyle modification, about the dietary changes, about the calcium and vitamin D intake, and the preventive therapy can be taken even though she is not having any symptoms of menopause. Next. Now, she has heard from one of the magazine that if a woman is taking estrogen, it will keep her active and young. The same thing was happening before the era of WHI when everyone was given hormone therapy and then the complication of hormone therapy were observed. So one should not prescribe any hormone therapy to asymptomatic women. Hormone therapy is restricted only to symptomatic women of menopause and in patients with premature ovarian insufficiency or high risk for development of osteoporosis. Otherwise, you should give her advice regarding the lifestyle in form of exercise, yoga, medication, calcium and vitamin D intake. Next. Now in the same patient, if she is complaining of irregular periods since 6 months, lasting 3 to 4 days in 25 to 40 days, 60 days, 90 days, and her LMP is 2 months ago, and she is using condoms for contraception and she has not visited gynecologist after her last delivery. Her BMI is 26, blood pressure is 120/80, and her TSH is normal, FSH is normal. So she is group 1 patient without disease. Now what will be what are her concerns? First concern is this menopause? So this is not menopause, this is menopause transition. Her second concern is, can I get pregnant? Yes, she can become pregnant in this age group, so she should use some form of contraception. And third concern is, are the irregular cycles normal? Then the answer should be yes. Irregular cycles, scanty periods are normal in the menopause transition, and it is also a surrogate marker for incoming menopause. Next. So irregular scanty periods are surrogate marker for menopause. Next. Now same case, 46 years lady, but she reached menopause 2 years ago. That is at the age of 44 years. She is symptomatic, complaining of hot flushes. Her occupation is beautician and her concern are there is growing more coarse hair on the upper lip and chin since the time of cessation of her periods, and she is gaining more weight, especially around the waist and hips. So she is group 2, that is menopausal with symptoms. This is wrongly written. Next slide. So regarding the weight, what is happening at the time of menopause? There is estrogen deficiency, and because of estrogen deficiency, the estrogen-androgen ratio is altered, so androgen axis can be seen, and this is the reason that there will be a collection of fat around the belly. This is also called, in the lighter note, that the body expands to accommodate all the love and wisdom that comes with aging, and the only proven solution to it is diet and exercise. What happens? There is a redistribution of the weight from a gynecoid to the android form, and it has been established that there is no increase in weight with hormone therapy unless it is progesterone sensitive. Next slide. Next. So it is the imbalance of estrogen to androgen that causes waist gain as well as appearance of the hair on the upper lip and chin. Now coming to the symptoms of menopause. Which are the symptoms? So these symptoms can be divided into physical symptoms, psychological symptoms. Next slide. Physical symptoms, psychological symptoms, vasomotor symptoms, and regarding the sexual domain, where prevalence of symptoms in physical are 74%, vasomotor 60%, psychological 44%, and sexual domains 26%. Indian women are having all these type of symptoms, and this is the Indian data. Next slide. So in this case, what is the treatment of choice? So as the patient is having significant hot flushes, and after ruling out all the contraindication to the hormone therapy. Hormone therapy is the option of choice. Next slide. So this is by the X-ray who are the candidates for menopausal hormone therapy. So in the vasomotor symptoms, hormone therapy is the gold standard. Then in the patients with prevention of bone loss in high risk to development of osteopenia and osteoporosis, in patients with premature ovarian insufficiency, in genitourinary syndrome of menopause, but there should not be fixed doses and fixed type of hormone to be given to the patient. There should be individualization where every patient should be considered separately, and according to the patient's need, the hormone therapy is to be designed. During the WHI publication, it was a mantra that there is a smallest effective dose for shortest duration, but now the dictum is adequate dose for adequate time. So the patient selection should be right. It should be given at the right age, that is within 10 years of the menopause or below the 60 years of age. One should give right hormone, estrogen to hysterectomized patient and estrogen plus progesterone to the non-hysterectomized patient. It should be given in the right dose according to the symptoms and need of the patient. It should be given through the right route, oral route, for no contraindication to oral therapy, otherwise transdermal route, or in cases of genitourinary syndrome of menopause, it should be the vaginal route, and it should be for the right duration. Next. So which are the drugs that are used as menopausal hormone therapy? First is estrogen in hysterectomized patient, then estrogen plus progesterone when uterus is there. Then we can use SOMs in form of either tibolone, raloxifene or ospemifene, which is not yet available in India, but very soon it will be available. And one more, tissue selective estrogen complex, that is TSEC, desodoxifene plus primerin combination. Next. Routes of administration are, in cases of oral estrogen therapy, the conjugated estrogen in standard dose, it should be given in the 0.625 milligram. In low dose, it should be 0.3 milligram, and in high dose, it should be 1.2 milligram. If you are using 17 beta estradiol, then the dose is 1 milligram. If you are using estradiol valerate, then it is 1 milligram. And for ethinyl estradiol, the dose is 5 microgram, which is not available. And because synthetic estrogens are very potent and can have more side effects, so synthetic estrogen are not used in patients of menopause except in cases of premature ovarian insufficiency, where till the age of menopause, that is up to the age of 46 years, low dose COC can be given. Next. Routes of administration, either oral or patches or vaginal route. Patches or gel are specially preferred where enterohepatic circulation is you want to avoid in special circumstances. So this is all about this case. Raju, Dr. Rajendra, can we go for the next case, please? Or we will go for questions? Rajendra.
Yes, sir. I was unmuted actually. I mean, I unmuted myself. So, yeah. So you have summarized it very well about the menopausal hormonal therapies that we have today with us. And like you rightly said, at this age, there is a weight gain which happens, and so you so nicely put it that it is basically the body expands to accumulate. Accommodate all the love that is being bestowed upon them with aging, but I suppose they have to balance this love with a little bit of exercise and lifestyle modulation, which should come up simultaneously along with aging. So that is one aspect which I would like to stress. I would also like to stress that what he rightly said about MHT should be used for vasomotor symptoms, for preventing bone loss, for premature ovarian failures, and in cases of genitourinary syndrome. Again, also, I would say that it is safe to be used in the first 10 years after menopause and below the age of 60 years. And of course, where there are contraindications, since his talk was more on MST, I would like to add that there are some what you call CAMs, or complementary and alternative therapies also, which can be given using phytoestrogens. So these phytoestrogens are something, a whole group of them, including isoflavones and even black cohosh extract. In fact, there is a molecule, a new sort of a preparation available containing black cohosh extract, which has given wonderful results. So I won't go into the details of that, but I would just like to point out that these complementary and alternative medicines also are an option available to us in those patients in whom MHT or menopausal hormonal therapy is contraindicated, like patients with thromboembolism, or patients with active or recent angina, suspected current or past breast cancers, endometrial carcinomas, etc., or even with liver disease. So in such patients, one could consider the alternative medicines. So now moving ahead to the next and very important aspect of metabolic disorders and the metabolic syndrome of menopause, I would like to now move on to Dr. Ratnabali Chakravarti for her case. Session, Dr. Ratnabali, madam.
Hello, can you hear me now?
Yes, madam. Yeah, we can hear you.
Okay, thank you so much, Dr. Nagarkatti, for allotting this topic, which is very close to my heart.
Yes, I know, madam. I've heard you so many times.
Yeah. Thank you so much. What happens is it's a paradigm shift regarding heart attacks and strokes happening in the Indian woman after 40. If you just can recall your younger age, you would agree to me that we used to think, and we were told, that Indians are having less heart attacks than the Western counterpart. The women are to get less heart attacks than the male counterpart. And after the age of 60, the chances of heart attacks are more. And to prove it, like any other, ideas, it's absolutely wrong. And therefore, we are now focusing on, from our point of view as the physicians for the midlife woman's health, more on the cardiovascular problem prevention. I'm talking about prevention because once it happens, it becomes a burden not only to the society, to the family, etc. So when you are showing this case of 47 years of woman, our clientele, we get nowadays many women coming to us and asking what should we do? I'm just passing into menopause. Should I take HRT? What tests should we do? I'm very scared of breast cancer because my aunt has got so and so forth. Now, many a times we talk a lot of things to them regarding hormonal symptoms, urogenital, what to be given, but we forget about the cardiovascular problem because they are lost to us. Once they get the problem, they go to a physician, a cardiologist, and we are very happy that we have treated our menopausal patient, not knowing that we have not treated them, so they are now suffering and becoming a patient. So our job is to screen, to find out who are at risk of having cardiovascular problem in later life, and let's start at the age of 40. So can you change the slide, please? Yeah, can you change the slide, please? Next one, please. Yeah, so the prevalence. If you look at the prevalence, you'll find that it is much more than the COVID deaths. COVID deaths are occurring in a short span of life, but you can see this cardiovascular disease deaths are no less. By 2030, 1 year will get 23.6 million people dying from heart attacks and strokes. And if you look at the lower part, contrary to the belief that heart attacks and strokes happen after the age of 60, you will find that between 40 to 60, almost more than 40% of the men and women are getting the heart attack and strokes. And even at this point of time, from 20 to 40, it's almost 12%. So it's no less, rather it's almost competing with the old age problem. Next one, please. So this is number one, that it is happening quite early. Number two, the Indian scenario. Cardiovascular disease is the leading cause of death in India. And 52% of the death of cardiovascular disease in India occur before the 70 years of age. And the rate of increase in the cardiovascular disease in the developing countries is double than that in the developed countries. Next slide, please. So when we will go on to the pass on to the next slide, you will find regarding the myth of misconception of the woman getting less heart attacks. If you compare the lifetime risk of cardiovascular disease at the age of 40, if we take in the men 2 in 3, means 66%, women are not far behind. It's 1 in 2, that is 50%. If you scan each disease and its death, cardiovascular disease, coronary heart disease, and strokes. Next slide, please. So you will find that in each sector, the women are not far behind the men. Next one, please. So all these three myths have been broken. The women are to get heart attacks at about the age of 40 to 50 in the Indian scenario more than anybody else in the world. So why this is happening and increasing more after the woman becomes menopausal? It's a very easy question. Anybody can say, even your clientele will say, who is a software engineer, that I am not having estrogen now. So that's not a very big point to discuss. Next one, please. So we know from age-old days that endogenous estrogen is a cardioprotective hormone. So after menopause, we get more of an osteoporosis, dyslipidemia, heart diseases, and as it advances, we know FSH becomes high, LH increases, and estrogen decreases. All taken together, the plasma lipids and lipoprotein metabolism are also changed in the wrong way. Next one, please. So the beneficial effect of estrogen, which we knew, that is on increased level of HDL and when estrogen is not there, the increased level of HDL decreases. So that is not only the cause. There are a lot of other causes, not only others, but to look at the other lipoproteins, to the homocysteines. We should also look at the vascular factor, the relaxation of the vascular smooth muscle, which is very, very important apart from atherosclerosis. So that happens when estrogen is not there. Now look at the blood itself, the platelet adhesions and aggregation. Estrogen decreases it. So when there is less estrogen, there will be more platelet aggregation, adhesion, and the antioxidant effect. All of you are talking about that. We're eating antioxidant containing food, we're taking vitamin E, and so on and so forth. But estrogen itself is so much an antioxidant. When it is depleted in the body, it gets a lot of free radicals. Talk about the glucose and insulin metabolism. Estrogen takes care of it. And therefore, in the absence of estrogen in our body or less amount of estrogen in our body, we are more prone to become diabetic. Next slide, please. So 3 of the myths have been shown, and why we are at this point of time so much concerned is because we now have come to know that the precursor of the cardiovascular accidents is metabolic syndrome. And if we can identify metabolic syndrome, we can prevent it. So if there is something we know, the causative factor, it becomes easy to prevent it and therefore decrease the chances of cardiovascular deaths. Next one, please. So we have to identify as a clinician, whenever a woman comes to us at the age of 40, we look at any 3 of these 5 features. Whether she has got the central obesity, it will take only a plain tip to measure it. High blood pressure, all of it measures it. To measure in the blood the triglyceride level, the HDL level, and look for the insulin resistance physically with the physical features and weight of a test. In our country, we have got a lot of polycystic ovarian syndrome cases. and almost 40% of them later on turns to metabolic syndrome. And from the metabolic syndrome, they turn out to be cases of cardiovascular accidents. Next one, please. Next slide, please. Yeah. So studies have been done to find out whether metabolic syndrome has got some gender difference. Is it affecting more men? No. If we take into consideration these 500 people have been tested in the National Institute of Medical Sciences, it was found that the age group was 55 to 56 years, that women are more having metabolic syndrome, 29%, compared to the men who are 23%. Next one, please. Which is statistically significant difference. Is it any problem in hearing? Should I talk louder? Hello? Hello?
Yeah, please talk louder.
Can you hear it?
Yeah, now it's better, madam. Yeah.
Okay, okay. So regarding this metabolic S and the cardiovascular risk, so if we look at it, that metabolic syndrome is associated with twofold increase in the cardiovascular outcomes and 1.5-fold increase. Yeah, so I'm holding it like this. 1.5-fold increase in the chances of other mortality due to other diseases. So this was a study which was done by the National Institute of Health. So here you will find that 87 studies were taken into account, which is almost 9,51,000. 10 lakhs of people were looked off regarding cardiovascular mortality, which is almost 2.5 the relative risk, almost 2.5 times. So looking into all this, if we can identify metabolic syndrome, then we will be able to prevent the cardiovascular disease. Next slide, please. Next slide. Yeah. So why this is so? Because after menopause, when the ovaries start secreting estrogen and testosterone, the androgens, the amount of estrogen depletion is much more than the testosterone depletion. Therefore, if we look at the ratio, there will be more testosterone. I'm not talking that testosterone is secreted more, but the depletion amount is less than the estrogen depletion amount. Therefore, the ratio is altered and androgens are more than the estrogen. So if this is the situation, the androgenic effect on the lipids and the vascular walls and atherosclerosis become much more. Next one, please. Next slide. Yeah. So now let's go further behind. If we are detecting metabolic syndrome at the age of 40 years, why can't we detect it earlier? Because in our chamber, when we are sitting, we are getting many more numbers of girls coming to us from the age of 12 to the age of 24, having irregular cycles, typical polycystic ovarian syndrome, then women coming to us with the infertility, then women coming to us with the dysfunctional uterine bleeding. All these are the points where we can scan, we can screen, and we can tell them you are the person who is going to have increased chances of cardiovascular problem, and this is our responsibility. So if you look at this metabolic S syndrome in a woman with polycystic ovarian syndrome, you'll find that cardiovascular disease, type 2 disease, diabetes mellitus, all are increased in these cases. Next one, please. Next slide. We'll hurry up because there's less time. Now, this we already discussed. Prevalence of metabolic syndrome in PCOS is 43%, which is almost twofold higher. Next one, please. Next slide. So this is our responsibility I was talking. Whenever we get a PCOS woman, a girl at an early age, we screen for the chances of cardiovascular disease starting from the history in her. Is it okay now? Is it okay? Hello? Is it okay?
Yes, madam, we can hear you.
Yeah, it's okay, but there's little bit of sound disturbance.
Can you hear now?
Yeah, better. Yes.
Because this audio I am finding out, it's showing here that it's not working. Anyway, I'm removing this. Yeah, can you hear now?
Yes.
Yeah, now it's better. It's better now.
Okay. So we have to screen the girls and women from the early age looking for the PCOS and then for the metabolic case, so that we can prevent later on. Next slide, please. Next slide, please. Hello. Yeah. So when a woman comes to us at the age of 50, she is no more menstruating. She is already complete. She has already completed a reproductive life. So how to know whether she had PCOS or not? Ultrasonography will not show any cysts in her ovaries because already they're depleted of the oocytes. So out of these 5 features, if we can take 3 of them, number 1, a history of irregular menses in the past. We'll look at the Hirsutism, which will be much more grave at this age. We'll look at the personal infertility or recurrent miscarriage, the history. We'll look at the central obesity, and we'll look at the features of the insulin resistance. Any 3 of the 5 present, even at the age of 50, 55, we will decipher that she had PCOS, she is prone to have metabolic age syndrome and cardiovascular accidents. Next one, please. So these are the study reports. Next one, please. Next one. I'm not going into details. So we can look at the surrogate features of cardiovascular risk evaluation, looking at the intima media thickness by ultrasonography. Very easy. We are doing in our chamber. Next one, please. It's very easy to do. Calcifications in the coronary arteries. Next one, please. Sleep disorders, sleep apnea and other sleep disorders. Next one, please. And we should tell her that if you have dysfunctional bleeding, endometrial hyperplasia, endometrial cancer, and host of these diseases like hypertension, obesity, dyslipidemia, type 2 diabetes, and cardiovascular disease, all this you are going to have increased chances of cardiovascular problems. Next one, please. And those who are having, glucose intolerance, almost 22% of them might become, with diet and exercise, a normal glucose tolerance, and 17% return to diabetes. Next one. This is the point when we can intervene and tell them. So we can just skip this slide. Next one, please. We did the study on this. Next one. Next one, we found the same result in the Indian population, eastern part of the country. Next one, lipoprotein A levels were increased in these cases. Next one, please. Next one. So this was a study report from the United Kingdom. It gives the same result. Next one, please. You can see over here the odds ratio. Cardiovascular disease, age-related, if it is 1.06, if she has got PCOS, is much increased, 1.36. Next one, please. Next slide. This is a very nice trial report, Women's Ischemia Syndrome Evaluation, where if a woman postmenopausal with a history of only irregular menses and elevated androgen levels with a high risk of cardiovascular syndrome, her chances of having heart attacks and interval heart attack is much more than in a non-PCOS cases. Next one. So coming to the end, so what should we do? We should look at the window of opportunity. When a woman coming to us at the age of 40, let's screen, let's describe, let's tell them, and let's refer them to the cardiologist to protect against the coronary heart disease and to reduce the new onset diabetes mellitus. We can put at the window of opportunity as soon she is having menopause in the next 10 years on hormone replacement therapy, which can prevent all those, not later on, which will worsen the situation. Next one, please. Next one. Yeah, so this is the trial report where the effects of hormone replacement therapy on MET-S in the postmenopausal woman was shown with the equine estrogen, esterified estrogen, transdermals. Next one, please. The last slide. Next one. So the conclusion was HRT reduces abdominal obesity, insulin resistance, new onset diabetes, lipid profile, the blood pressure, addition molecules, procoagulant factors, which are the components of MET-S in women without diabetes. And in women with diabetes, it reduces the insulin resistance and fasting glucose in women with the diabetes. So we can see very well that what we were looking earlier was different, that treating the woman after menopause with HRT to prevent secondary or primary cardiovascular disease. But now it is not the situation. As gynecologists, we from the very early age, we pick up the woman, screen the woman, and as soon as she reaches menopause, at the window of opportunity, we put her on HRT if it is suitable for her, and prevent further cardiovascular worsening situation. Thank you very much.
Thank you, Dr. Ratnabali Madam, for this elaborate talk on the metabolic syndrome. Just for the sake of the audience, I would like to add that there are different, various different criteria for diagnosing what is METS. There was different criteria by the American Heart Association, by the International Diabetes Federation, and then there was a final consensus which said that to diagnose it, it's basically insulin resistance with any two of the following: one, a waist circumference of more than 80 centimeters, a triglyceride level of more than 150, HDL cholesterol level of less than 50, a blood pressure of more than 140/90, and a fasting sugar level of 100 milligrams or greater. So she has already elaborated the various metabolic and dyslipidemic and other problems that are associated with menopause, and also the beneficial effects of MHT on the incidence of type 2 diabetes mellitus and on the other aspects. So definitely MHT has a role to play over here. So thank you, madam. And also I would like to point out that you had, I remember in one of your talks, you had specifically mentioned that during hysterectomy, if the ovaries appear normal, do not remove them, because the ovaries, even after the age of 50, 55, continue to produce estrogen and also some amount of androgens, which continue to help the woman in terms of general health, bone health, cardiovascular health, and even sexual health. So therefore, preferable to retain the ovaries, but to go ahead with a salpingectomy. So that particular point I would also like to bring out. And so now moving on to the last and final case and panelist, we have Dr. Parag Piniwale. So I would like to hand over the mic to Dr. Parag.
Yeah. At the outset, I would like to thank Dr. Rajendra Nagarkatti and Midlife Management Committee, and of course, my IMS family for inviting me here. I'm happy to share that we have accredited this CME by giving one ICOG credit point. So those who are listening to us, please.
Thank you, Dr. Parag, for that. Yeah, we need those points. So thank you.
Yes. So briefly, we'll just quickly move ahead with the next clinical scenario, which bothers so many of us, and that is abnormal uterine bleeding. And here I would like to discuss one case. A 63-year-old woman who had her second delivery about 35 years ago came to the clinic with the history of bleeding per vaginum. She gave history that she did have two such episodes. One was 1 week apart. She is a known hypertensive, controlled on medications. She gives history of mild diabetes, which is again controlled on oral medications. Her BMI is average. She is a known hypothyroid, again on treatment, and currently the levels are well controlled. She's not taking any other medications, which include hormone therapy or blood thinners. When we examined her, her blood pressure was about 140/80, and her local examination revealed that the cervix and vagina were atrophic. The uterus was normal size, mobile, and there was no fornical tenderness. Next slide, please. Right. We did counsel her, and of course, we did a pap smear, but her ultrasound report mentions that the uterine size is about 70/28/25 millimeters, and the endometrial thickness was 13.6 millimeters. Both ovaries were atrophic, and the adnexa and the pouch of Douglas were clear. So the question that comes to our mind is, what is the workup that we would advise her? And the next slide, please. Of course, we will ask her to have all routine blood investigations, which I will discuss in the next slide. Doing a pap smear at this point of time is very, very important. Especially smear should be done when she is not bleeding actively. Otherwise, the red blood cells are going to interfere in the interpretation. And here I would mention that we must obtain two slides, one of the ectocervix, and very importantly in this woman is of the endocervical sample, because it will be a pointer for the glandular activity that is going on. Of course, she will have to have a physician assessment for her so many comorbidities, and Ratnabali will also agree that these are also important aspects which need to be discussed. Now, ideally, when we talk about management of such a woman, once we do her routine investigations, when we do her physician assessment, obviously the next choice of treatment is hysteroscopy and endometrial biopsy. The second option will be PIPL, and I would here like to have opinion of my co-panelist and the moderator that in COVID situations where you would like to avoid administering anesthesia, you would like to avoid hospitalization, how accurate will a PIPL sample be? May I have Jignesh and Ratnavali to opine on this? I know it is perfectly not fair not to do a hysteroscopy, because when we are managing a woman who has postmenopausal bleeding, the first thing that comes to our mind is whether she has whether she has C endometrium, or if we are dealing with a polyp. But here, because of the COVID situation, she's not reluctant to get admitted in a hospital. She's reluctant to have a procedure under anesthesia, because now we know that even if we have to do a simple procedure of hysteroscopy under anesthesia, it will have to be something like saddle block, and we cannot, we may not be in a position to offer her general anesthesia. Ratnavali, you and Jignesh, your comments, please. Jignesh, your mic is off.
Dr. Ratnavali, madam, your comments on how accurate would be the PIPL cytology?
Yeah, it all depends on who is taking it. The one who is regularly taking it and experienced one, it gives a very good result. Almost 70 to 80% you will get a positive result, positive collection from there. But sometimes it happens that a woman is suddenly you are starting with your peoples, taking from with the peoples, and the result comes out to be very less. It also depends on the design of this people's curate which you are collecting. Some which we were collecting from abroad, it was coming, it's a bit costly. The result, the suction was much more. Nowadays, we get some from the local markets, which the suction capacity is not more. But once you collect it and it send you to the pathological lab, it's fine enough. Whatever you get, you will get a perfect, good histological report. So it must be the first step to collect something, whether with people or with anything else, without anesthesia. If you can collect it, that's the best. And looking into this COVID-19 situation, as Parag was telling, you have to put saddle block or something else. So we are trying to avoid. But maybe we have to come to a conclusion that we have to take it. And
maybe even a hysteroscope, office hysteroscopy would probably be useful here, where we don't need full anesthesia.
See, probably if it is a woman is round about the age of 45, 50, 52, even the cervix is fine enough. But if really in a postmenopausal bleeding, 65 years, 68 years, the cervix is so much pinhole it has become. Now it becomes very difficult to even insert a office hysteroscope.
Absolutely.
And if you want to take a sample, that also becomes extremely difficult.
Yes, I agree with that.
We should consider only doing a DC, the age-old procedure with a bit of an intravenous, total intravenous anesthesia, which takes a very less time. So you need not put anything, not even LMA, and therefore avoiding any spread of COVID-19. Also in our hospital, we are doing a COVID-19 testing. After 2 days, when the report comes, then only we are asking the patient to come for the tests. So this is how we are proceeding, and maybe next 2 years we have to do that.
Right. No, I totally agree, Ratnavali. Can I have the next slide, please? Totally agree with you. I mean, if I'll have to reassess the cervix and see how things are. Now, when we talk about abnormal uterine bleeding in general in the menopausal age group, of course, we will have to do these investigations where we would certainly have a look at her hemoglobin, CBC, and platelets. Women who are not in this woman, but women who are in their 40s, we would certainly like to rule out a pregnancy test, especially if they are sexually active, if they are not using any contraception, and if the cycles are irregular, and of course, if they are not sterilized. thyroid dysfunction is something which we have to be vigilant about, because many a time it so happens that the thyroid dysfunction appears for the first time in the perimenopausal phase, or when the woman attains menopause. Next slide, please. Right. So when we talk about this particular woman, I think you've skipped one slide. No. All right. Okay. What is the role of imaging? Now, when we talk about investigating women who have abnormal uterine bleeding, the best modality is to do a transvaginal ultrasound. Second option is to do a MRI. But please note, any woman who comes to us with perimenopausal bleeding, or even women who are more than 40 with some heavy menstrual bleeding, need not undergo hysteroscopy in all cases. But the only thing that is very, very important and which must be done is a good transvaginal ultrasound, where we want to have a look at the uterine cavity, where we would like to know the endometrial thickness. Polypi can best be diagnosed by a 3D ultrasound or even by saline infusion sonography. Of course, it is important to rule out adenomyomas and fibroids in these cases. Next slide, please. Right. So in this woman, what we plan to do is to, we've counseled her. Now she has to come back to us with the consent. Now, if she agrees for a hysteroscopy, we would post her for hysteroscopy. Otherwise, we will go ahead and plan a PIPL, which is done on an OPD basis. And her further course of action will be taken as per the histopathology report. And if the histopathology report says that it is proliferative, we can just observe. We can counsel her that she has to do a regular follow-up right now telephonically. Some women who are concerned about bleeding, one can think of giving progesterone, but please note that we must counsel the woman that she will experience withdrawal bleeding once we stop progesterone. If the report is hyperplasia without atypia, now whenever we are talking about hyperplasias, we are dividing it into only two groups. Now simple, complex, etc. is gone. Hyperplasia without atypia, the treatment is by giving progesterone, and for this particular woman, LNG intrauterine system would work well, and hysterectomy would probably be the second choice. And if a woman has hyperplasia with atypia, obviously the choice would be hysterectomy. And if unfortunately, if the diagnosis turns out to be CA endometrium, we will reassess her by doing an MRI, where we would like to know about the myometrial invasion, we would like to know about the lymph nodes, and we would go ahead with the surgery as per staging. If she's not fit, we may have to think about doing a radiation therapy. Next slide. Right. So when we talk about diagnosis, it is extremely important that we take history, we do a good clinical examination and find out what is the size of the uterus, and imaging will give us a good clue as to what exactly we are looking at. So if we are suspecting a polyp, a good transvaginal ultrasound with saline infusion will give us a good choice where the intracavitary mass will be outlined. If you are dealing with adenomyosis, it would be a globular uterine enlargement. There would be thickening of uterine wall, and there would be obscuring of endomyometrial junction. In women who have leiomyomas, of course, the uterus will be enlarged depending on the size of the uterus. It will be irregular, firm, and these fibroids can, of course, be diagnosed by a good ultrasound. If 3D ultrasound will be of use where a transvaginal ultrasound cannot be done, especially in an inactive, sexually inactive unmarried girl. And exact location of fibroids, especially if it is big, can also be found out using MRI. When we are suspecting malignancy and hyperplasia, ultrasound will be a good tool where the thickness of endometrium, if it is more than 12 millimeters, we must start suspecting endometrial hyperplasia or CA endometrium. Next slide, where the diagnosis will have to be confirmed by endometrial sampling. Coming to the other aspects of coagulopathy, ovulatory disorders, endometrial factors, and iatrogenic, here the examination findings more or less will be will not reveal any specific finding. even the imaging may not be of great help, but we must look for small ovarian cysts, we must look for polycystic ovary, or presence of fluid in the endometrial cavity. And if as far as the iatrogenic factors are concerned, we must take history of hormone therapy, the menopausal hormone therapy, and the intrauterine device use. I think that's it with my presentation. Thank you.
Thank you, Parag, for this discussion on AUB and postmenopausal bleeding. Like you said, we would like to once again stress that hysteroscopy is the gold standard for diagnosing in such patients. And in today's times of COVID times, we have to look at alternatives that we need to consider. I'm happy to see that there are a lot of questions, and even we have international audience with us. We have Dr. Cezelio Mesembe from West Africa, and we also have Dr. Daniel Mutua from Nigeria. We have audiences from Nepal and even from Sri Lanka. A very nice feeling for the Midlife Management Committee that this topic has generated a lot of interest. So thank you everyone for logging in such large numbers. So I think we could start taking some questions. There is a question for Dr. Jignesh by Dr. Atul Munshi on your view for making a mother out of a grandmother. I think even Dr. Pratik could answer that probably.
And it is very controversial. But in our speakers panelists, we have Dr. Ratnabali, Dr. Pratik Tambe. So better you ask them.
I think Dr. Pratik could answer. Although I would say that he's already given us the point that in these elderly mothers, there are more problems of carrying on with the pregnancy, especially the medical problems of diabetes, hypertension, etc. Yes, Parag, you would like.
Raju, here I would certainly like to point out that when we are discussing about grandmothers, we are talking about menopause or perimenopausal women. We have to strictly follow what ICMR has suggested us. I think the ICMR says that 45 is the limit, though our federation feels that it could be raised to 50. But when we read in the newspapers that a 65-year-old woman became pregnant, or a woman who was in her 70s became pregnant, I think that is against, and we must oppose it point blank.
Absolutely
maybe
right.
ART consultant or menopause practitioners like us, we have to oppose such.
So especially
acts.
When I started off with the case, I clearly mentioned the age being 42.
Yes.
I specifically kept it less than 45 because I knew this issue is going to come up. Unfortunately, in India, we have a lot of good guidelines. We have conscientiously practicing consultants. But sometimes what happens is patients sometimes hold a gun to our head. And this is the time when we have to be very specific and we have to counsel them and we have to make sure that they choose the correct option. Our role as a guidance counselor and as a person who is like an angel giving the right advice at the right time cannot be underestimated at this time. This is what our teachers taught us, that you need to be able to speak to the patient in the language which she understands and guide her towards the correct option. You could keep all the options on the table, but you have to be able to guide her in the right direction. Not that because you are going to make money out of it, or because the patient demands it, you give in to that pressure and you crumble. That should never be the case. I totally agree with what Parag said.
Thank you.
My clinical experience says that when we are doing cesarean of 50 years plus lady, there are even without any comorbidities, the chances of atonic PPH are maximum.
Very
about
true.
the patients with diabetes and hypertension, even in normal patients, the atonic PPH incidence is high. It's because of the condition of the arterioles.
Absolutely, sir. Right. We have a question from Dr. Seema Kaure. I think Dr. Ashwin has already answered this, but the question is for how much time local estrogen cream can or should be prescribed?
Dr. Seema, we can definitely give local estrogen cream safely till 1 year. But you can assess the patient and you can give maybe even lesser duration of time. You can start with every day night she can use the cream. You can tell her to use that like for 2 to 3 weeks or even 1 or 2 months every day. Then taper it off. Either make it alternate day and then make it twice a week and see how she is symptomatically. And if she is better, you can continue then with this lesser dose, maybe twice a week or something. And the studies tell us only 1 year is safe, but there are so many clinicians who have given even longer than this and they have not come across any major side effects. But any patient who is on any drugs for a long time has to be under surveillance and supervision.
May I add one point, please?
Yes, ma'am.
Yeah. So estrogen vaginal local creams are of different types. If it is an estriol cream, which we used to use as the Evalon, estriol cream once a day doesn't cause any problem because it remains within the nucleus of the endometrial cells only for 8 hours. And for the cell division, it has to be there for more than 18 hours. So nothing happens. But if we give the conjugated equine estrogen cream or 17 beta estradiol cream directly, they remain within the nucleus for 24 hours, more than 24 hours. And there will be cell division, and after a long period of time, if we don't look at the endometrium, there are chances of endometrial hyperplasia. Therefore, our guidelines, Indian Menopause Society does not ask to give it more than 1 year, twice weekly. But if you want somebody is very good on it, whenever we are stopping, she's having symptoms, you have to look at the endometrium continuously and do it.
Absolutely.
Thank you, madam, for this input that one has to keep watching the endometrium, and also that probably estriol is the better choice because of its shorter life within the cells. Moving ahead, we have a question from Dr. Madhurban Singh from Nepal. For Dr. Ratnabali, is estrogen replacement cardioprotective? I think she mentioned it in her case, but yes, I would like to have her comments again.
Yeah, again the comment, because it can be emphasized every day. So it's the window of opportunity. As soon as she becomes menopausal for the next 10 years, this is the window of opportunity when the vascular changes have not taken place. So during this period, if she needs, we give her estrogen replacement therapy or hormone replacement therapy, which also contains progesterone, that will prevent the vascular changes and thus will decrease or not postpone, but will decrease the chances of cardiovascular accidents. But after 10 years, when the window of opportunity is closed, if somebody starts using HRT, that will cause more harm by increasing the chances of cardiovascular disease and strokes.
Yes, Dr. Madhurban Singh, there are a lot of studies. There is a Swan heart study which has clearly proven the beneficial effects of estrogen as a cardioprotective. And like Madam said, everyone needs to remember that it is the window of opportunity that we need to concentrate on and try to give them the MHT before they turn 60. Yes, Parag?
Yeah, Ratnabali, if you will remember, in the 90s, we all used to prescribe menopausal hormone therapy for prevention of heart attacks. That was the dictum
yes,
in
but
the
that
90s.
Is no longer, yes.
That is no longer true, and it should not be used. Once the very rightly pointed out that it should not be used as a first-line therapy for prevention of
Yes. We have a question from Dr. Reena Vani, Madam. Thank you, Dr. Reena Vani, Madam, for joining us on this webinar. The question is for women who have hot flashes, should we avoid SERMs as they have aggravating effects? And also there was a question as to what is the management of vasomotor symptoms. So I think probably Dr. Jignesh would answer this.
Management of hot flushes we have already discussed. The estrogen is the drug of choice if it is not contraindicated. If estrogen is contraindicated, then we should go for either venlafaxine or paroxetine, or sometimes only estrogen if it is not giving results, then we should combine it with estrogen with venlafaxine or paroxetine.
Thank you, Dr. Jignesh. What do you think about gabapentin? Is it? I mean, it would be a second choice, I think, after the SNRIs and the SSRIs.
Yes, gabapentin can be a choice. Yes.
Okay. Thank you, sir. We have Dr. Pragya Mishra also, who has joined us from Patna. Thank you, Dr. Pragya Madam, for joining us. The question is for Dr. Ashwini Bhalarav Gandhi. Please suggest something for a 45-year-old multiparous woman weighing under 40 for symptoms of severe atrophic vaginitis and urinary hesitancy, who has tried local and oral estrogens, which did not help her much. And she had to undergo urethral dilatation under GA, which helped her for 5 years. And now again, she's back with the same problem of urinary hesitancy due to atrophic vaginitis.
I think the fact that she has to undergone urethral dilatation, maybe we have to do a urological checkup and urology reference also, and maybe they can evaluate her with uroflowmetry and any other tests which they feel are required, because maybe it is a urinary problem totally, and we are because she's also having vaginitis and infection, we are blaming menopause for it. So I think a thorough urological evaluation is important, and also maybe we can see that she doesn't have diabetes, and we can give her probiotics orally, as well as now vaginal probiotics are available. If they are going to change the flora of the vagina, and the vagina then becomes healthy and the discharge becomes less. And I'm sure Dr. Pragya must have already evaluated her for any dysplasias, etc., and done her pap smear. That is not the cause, that any changes in the cervix which are leading to the repeated infection and discharge.
Pragya Madam, this has answered your query. Thank you for joining in. We have Dr. Ganpat Sawant, who has joined in, and he says hi to everyone, and he has congratulated us on the quality of the webinar. So we have to say thanks to TOG for this. Dr. Pratik Tambe himself has a question for how long should hormonal replacement therapy be given. There's also a question by Dr. Cezelio Mesem from West Africa, who has the same question. For how long should HRT be given?
So now, one thing is sure that we are not using the word HRT. Now the word is menopausal hormone therapy, and HRT is only used in the patients of premature ovarian insufficiency. So in patients of POI, we can give HRT up to the age of natural menopause, not contraindicated. In postmenopausal patients, if we are using menopausal hormone therapy, then the safety data says that for estrogen plus progesterone, it is 3 to 5 years. And if you are using only estrogen for hormone therapy, then it is up to 7 years. But it should be below 60 years of age within 10 years of menopause to start.
Thank you, Dr. Jignesh. There is a question from Dr. Daniel Mutua from Nigeria. He would like to ask about the products for climacteric symptoms. What products would you recommend for climacteric symptoms? I think probably what he means is the complementary and the alternative medicines that are available. I can know of one product, that is remifenin, which I mentioned about earlier, that is black cohosh extract, and this is a wonderful molecule. Basically, it is Sinifuga racemosa, which is a black cohosh extract, isopropyl alcohol extract, and it has been approved in various countries, It has multiple actions like estrogen activity. It serves as a phytostim. It is serotonergic, dopaminergic, and it has got it's given a lot of beneficial effects. Even the isoflavone products can be used. These are what we call phytoestrogens, which are a group of plant chemicals which elicit an estrogen-like response. Yes, the potency or the efficacy of these drugs is almost 1,000 times less than the actual estrogens, that is like estradiol valerate. But like I said earlier, also in patients with mild symptoms of climacteric symptoms, probably we can use this, and especially where there are contraindications or there are certain restrictions for giving MHT, we could probably use these molecules. There is a question by Dr. Ada Okpige from Africa. How do we address the issue of reduced libido in menopausal women using medications? I think I could ask it open to any of the panelists, or probably Dr. Ashwini.
For libido,
yeah, the question is on loss of libido.
If we are giving only estrogen and if still woman is having lack of sexual desire, then we can add androgen. But in India, oral androgen therapy is not available except in form of DHEA. So we can give androgel locally for this. Otherwise, tibolone is a better alternative where it is estrogenic, progesterogenic as well as androgenic.
That's wonderful. Thank you, sir. There's a question by Dr. Ashita Srivastava. What drug apart from frontibolone can be given to a patient for hot flashes in a patient of endometriosis post total abdominal hysterectomy with BSO?
See, here when we are talking about hormonal therapy in a woman who has undergone hysterectomy for endometriosis, the dictum is to add progesterone even if the woman has...
There is no uterus.
Yeah. Even normally when the uterus is intact, we would add progesterone. But in cases of endometriosis, even if the uterus is out, the ovaries are out, we would use progesterone in order to stop proliferation. Of course, tibolone is supposed to be better than estrogen-progesterone combination.
Thank you, Parag, for the input. We have a congratulatory message from Myanmar, who says, this is Dr. Zaire Nian, who said this is a very informative and precise presentation about the menopausal women. Thanks to all the speakers. His question is, my question is, should we consider PCOS among perimenopausal patients, and do we need to treat them? I think Dr. Ratnabali could...
Ratnabali has already discussed.
Yeah, it's already discussed, yes. So I think we could move on. This is a question, a 54-year-old woman with mild flushes, no diabetes, no hypertension, thin endometrium, ovaries small. She's worried about bone loss, vaginal dryness on tibolone. She felt more weight gain. Should we give her any HRT or not? People still use the same term, so this is reading it from the question. Should we give her any HRT or not, short term or long term, and what supplements for body fitness? This is from Dr. Mala Saxena.
Can we know when she had the menopause, the last period?
That is not mentioned here, madam. It's
because again we will stress on the fact when we have. So 10 years down the line, we can give anything, whether tibolone or estrogen progesterone, doesn't matter. But if it is past 10 years, then we cannot start it and we have to go for anything else. And during this period, whatever suits her, we can give. And regarding her vaginal, if it is only vaginal, we can give vaginal local estrogens. Along with, for the bone protection, we can give a lot of other things. The bisphosphonates are there. So those two we can combine. The combination products are coming from abroad, the bezidoxifene and others. We probably have not them, in a proper market. So we can give separately for a vaginal cream as well as the bisphosphonates if she is past 10 years and doesn't have any symptom of vasomotor and others. Only for urogenital symptoms, we are not going to give the oral therapy.
Thank you, madam. I'm happy to share that we have a very well-known, iconic Dr. Sunila Khandelwal, madam, who has also joined us, and she would like Dr. Ratnabali, madam, to share the Indian criteria for diagnosis of METS.
Indian criteria for diagnosis of metabolic syndrome?
Metabolic syndrome, yeah.
Yeah, that you have told. You
Yes,
have already described. So I think she has missed it. So it has been described properly. So I think we can skip on it.
Okay, madam. There's a question by Dr. Heinz Iseo. What if the patient doesn't want ERT? What supplements can we give in place of it?
We would discuss it, no?
It has already been discussed.
Yeah.
There is a role of chemotherapy. If patient is unwilling for hormone therapy or hormone therapy is contraindicated, then we have to think over the chemotherapy.
Yes, I think that's about all. I would just like to stress one thing over here that again, like madam has mentioned about the window of opportunity, this is the age where when they come to you at the age of between 40 and 50, that is a window of opportunity to also try and catch them for prevention of osteoporosis, because bone health is something again which tends to deteriorate after this age. So therefore, we need to also stress them upon the adequate use of calcium, vitamin D, and also exercise, adequate sunlight, and probably also need to check the bone density from time to time, and if necessary, take appropriate preventive measures for osteoporosis. Yes, ma'am?
Yeah, nowadays we say that prevention of osteoporosis should start from the intrauterine fetal life. So we have to give the mother enough calcium, vitamin D3 and protein so that it passes on to the fetus and gets a good amount of calcium in the bone. And after birth till the age of 22, 23, she should get enough calcium, vitamin D3, protein and exercise. Nowadays the last is lacking. Everything is being given excepting the exercise. So the bones are not getting enough deposition of calcium, and easily osteoporosis and fracture happens later on when she starts losing bone. So this has to be told carefully that it's not a menopausal problem. It starts from the intrauterine life, and in the adolescence and in the early reproductive, after childbirth, she should get, if she is breastfeeding, enough calcium, which is absent in real Indian food. So it should be, banged on regularly.
Absolutely right. And in fact, this is a very good point that you have brought out on the eve of Mother's Day. Tomorrow is being celebrated as Mother's Day. So you rightly pointed out about this particular aspect, that mothers need to be given adequate amount of calcium.
Again, we are talking about mother of the mothers.
Yes, sir. There's a question again from Dr. Sunila Khandelwal, madam. Which is the best COC combination for premature ovarian failure? The ideal doses and how long should it be given? Sorry. This is a question by Dr. Nupura. Which is the best COC combination for premature ovarian failure and how long should it be given? Workup in future to avoid or prevent adverse effects.
The best combination is 20 microgram ethinyl estradiol combination. Whatever the preparation with low dose of synthetic estrogen is available, that is 20 microgram of ethinyl estradiol is available. But nowadays, even 17 beta estradiol with dydrogesterone combination is available.
Yes,
so alternative, it can be given too.
Yes.
It depends on the cost factor as well.
You have to consider the cost factor.
Cost factor. It has to be taken for a long period of time. And therefore, as Jignesh was telling, in the early age, the low-dose oral pills with less androgenic progestogen, with desogestrel maybe, that can be continued till the age of perimenopause, when we can then switch on to the natural estrogen and dydrogesterone. But if she can provide it from the early age, she can take it. Dydrogesterone is a very good progesterone. So that can be given from early age, but it's quite costly.
Dr. Ratnabali, we can also give oral contraceptive pills with drospirenone. And especially if the obesity is there or the hypertension is there, maybe it will be useful. Every drug has its own side effects, but these are the various drugs which are available, and we can choose from what are her other problems and comorbidities, and accordingly
even topical creams are available in patients in whom the oral preparations would be contraindicated. And there is estrogel which is available, which can be used. There is a question from Dr. Reena Vani, a woman with total abdominal hysterectomy with BSO, which was done for ovarian disease like endometriosis. If she develops severe symptoms, menopausal symptoms, then what is?
We already
discussed.
answered.
I'm happy to announce that we have reached 1975 logins, almost 2000. Fantastic. So thank you, everyone. And there is one more question. If in a case of a surgical menopause at the age of 45, what would be the choice of HRT?
Because in surgical menopause patients,
there is an abrupt.
All the patients do not require hormone therapy. If patient is symptomatic, then and then hormone therapy is to be given in surgical menopause patient if it is at the age of 45. If it is done earlier, then we are supposed to give hormone therapy. So if she is having symptoms, if she is symptomatic, then the combination can be either only estrogen therapy, or it can or Tibolone can be given in these cases.
Yes, Tibolone also is a good choice. And yes. Okay, sir, thank you very much.
Estrogen has to be given instead of oral. We can go for the patch or even the transdermal cream.
Yes.
So that will be with less side effects.
Okay, Raju, here I would like to make a point which Ratnabali has already stressed upon is if we retain the ovaries, it is possible that the menopausal symptoms may not appear immediately. So whenever we are thinking of doing an hysterectomy in a young patient, say at the age of 45, we have to put in all our efforts to preserve the ovaries, right?
Yes,
even if the woman is 55, 60, 65, if the ovaries appear normal, it is prudent that we keep them in order to prevent the problems related to the bone and muscle health.
In fact, we are not only preserving ovaries, but looking at the current scenario in the cities and in the sub-metros and in the suburban areas, in the rural areas, a lot of uterus are also being removed. We don't know the function of all the organs of our body properly till now. So unnecessary removal of uterus should also be, we should also talk on that. We should prevent that, and we should discourage that. So it's not only the ovaries, but also unnecessary removal.
Hysterectomy is also, yes. That's a very, very, very nice and a poignant message that you have given, madam.
Save the uterus. In the lockout period, we have seen that without hysterectomies, women are living.
Yes. There is a comment. Nice discussion. Where is Pratik speaking from? As his background is different.
He's speaking from Mars. Yeah.
He's above us, so I think that's wonderful, Pratik. What is the chances of getting breast malignancy in a case of endometrial hyperplasia? Measures to prevent that. This is a question from Dr. Swarna Raghuram. Do we have information after hysterectomy of young people? Do we need to hormonally follow up these women? This is from Israel, Dr. Sergey Jones from Israel. Chances of breast malignancy in a case of endometrial hyperplasia and measures to prevent it.
So as far as breast malignancy is concerned, yes, there is a very small and real risk of increased incidence of breast cancer when you administer menopausal hormone therapy to women. But the International Menopause Society guidelines say that this can be reduced by using micronized progesterone or dydrogesterone, which is what we prefer today as compared to 5 or 10 years ago when we used to give synthetic progestrogens. So this is the current evidence as it stands. This is the simplest and shortest way I can address the question.
No, probably the question was different. If somebody is having endometrial hyperplasia, what is the increased chances of having breast cancer in that woman? Which,
even without MHT, even without using MHT.
Not only with the MHT. So here the amount of estrogen, circulating estrogen in the woman's body is being pointed at. So whether her breast has got estrogen receptors or progesterone receptors, and depending on or BRCA1, BRCA2, so on and so forth, very complicated. Only excess estrogen in the body will not cause breast cancer, increased breast cancer. So endometrial hyperplasia in a woman per se is not going to
increase the risk for breast cancer.
There are a lot of other host of other factors.
Thank you, madam, for that. This was actually a question from Swarna Raghuram, and we have this question from Dr. Sergey Jones from Israel. Do we have information on ovarian failure after hysterectomy of young people?
Yeah, definitely we have.
So do we need to hormonally follow up? Do we need to hormonally follow up these women after?
Definitely. Yeah.
Raju, I would say that rather than hormonally, we will go by the symptoms.
Do the
symptomatic. Okay.
Yes.
So not only a symptom,
we need to
but
remember that possibility is there. There is ovarian failure probably because of a decreased blood hysterectomy. So we need to remember that and proper follow-up is necessary.
Simply doing an
the other women,
yearly they will give an indication whether the ovaries are failing or not. So when the ovaries start failing, we can put her on proper therapy so that maybe at the age of say 35 she has lost her uterus, and if we follow her up and at the age of say 39 she is showing that FSH is rising, we can put her on very simple oral pills so that she gets enough estrogen and therefore will not develop the other problems, the long drawn problems of estrogen deficiency in future.
So would you, up to what age would you recommend the regular oral pills? I mean, in terms of ethinyl estradiol, because it is supposed to be much more.
Till the age of perimenopause in our country, perimenopause is 47, 48 years. So till then you can very well give it and then switch on to the natural estrogens.
Okay. Thank you, madam. There's a very nice question from Dr. Meenal Mahendale. Are there any chances of spillage of endometrial cancer cells during hysteroscopy?
See, previously we always used to
feel cavity. Spillage into the
previously we always used to feel that there would be spillage of endometrial cells into cavity, especially if the tubes are open. But now there is enough literature which does not support that. And if at all you are worried about it, you can always keep the intrauterine pressure low when you are doing the diagnostic hysteroscopy.
Yeah, thank you, Parag, for that.
It's already 7 p.m.
Yes. I'm happy to say that we have had an audience from across the length and breadth of India and also from
abroad.
Like I've already mentioned, Sri Lanka, African countries, Myanmar, Israel.
France.
Thank you.
Somebody from France.
One question. I think probably we could take this as the last question from Dr. Preeti Prasad. Question: if on cervical biopsy for postmenopausal bleeding, chronic inflammatory changes are observed, then what should be the management? Parag is shaking his head. So
I think when we are doing a good pap smear supported with colposcopy, the need of cervical biopsy is almost gone.
Okay, but if there is this of chronic inflammatory changes,
Doesn't matter.
Nothing.
You can
Nothing
keep
to
on
be done.
observing her.
Okay. So thank you everyone, and I hope the audience has had a good amount of insight into these problems because of our expert panelists who have answered all the questions to the point, and we have had this discussion going on for the last 2 hours. So once again, I wish to thank our panelists, Dr. Jignesh Shah, Dr. Ratnabali Madam, Dr. Ratnabali Madam, Dr. Pratik Tambe, Dr. Ashwini Bhalerav Madam, and Dr. Parag Biniwale. And I wish to once again thank the Bharat Serum and Vaccines Limited and the TOG for helping us in conducting this webinar. And of course, the FOXY Midlife Management Committee and the Indian Menopause Society for together hosting this webinar. So thank you everyone.
Thank you, Raju.
Thank you so much, everyone.
Yeah.
Thank you everyone, and
Thank you for
we'll
including.
meet again. Thank you.